everyone, and a very warm welcome to you, wherever you are joining us from across the globe. I am Mira West from the Foresight Institute of Research and Translation, FIRAT. We are honored to have you with us for the launch of the second edition of the Mental Health Dialogue Series. At FIRAT, our mission is to ensure that scientific discovery doesn't just sit in journals, it must transform lives. That is why today's theme is so critical: bridging research and reality, mental health as a human right in LMICs. For too long, there has been a gap between policy papers and the daily struggles of communities in low and middle income countries. Today, we bridge that gap. To guide us through this important conversation, I am delighted to introduce our host. She is a distinguished public health professional and a relentless mental health advocate. As a founder of the HealthWave initiative, she has dedicated her career to integrating mental well-being into broader public health systems across Africa. With a strong background in health communication and mentoring young professionals, she currently volunteers with the Impact Mental Health Support Group in Nigeria. Please welcome our host, Ms. Owosinke Victor Achibong. Joining Ms. Achibong today is an extraordinary panel of experts who are working on the front lines of mental health care. First, we are honored to welcome a veteran from Pakistan. She is a gold medalist in psychiatric nursing and a seasoned RMNCAH expert with over 20 years of experience. As the CEO of Ishad Amtu Reproductive Health and Midwifery Services, she collaborates with the WHO and the Ministry of Health to drive national initiatives. We are privileged to have with us Ms. Musarat Rani. Next, joining us from Malawi, we have a dedicated humanitarian. He is a community social worker, psychologist, and specialist in mental health and psychosocial support. Since 2015, he has been working tirelessly at the Dzaleka refugee camp, collaborating with the UNHCR and World Food Programme to bring healing and resilience to displaced populations. A warm welcome to Mr. Vincent Balume. And completing our distinguished panel is a passionate, results-driven advocate. With over 5 years of experience working with institutions like the MPG Forum for People Living with HIV/AIDS, he is the co-founder of Psych Care Uganda. He is doing vital work promoting mental health awareness among adolescents and school stakeholders. We are pleased to welcome community psychologist and mental health advocate Nas Asadu Mubanda. Distinguished guests, ladies and gentlemen, the stage is set. Ms. Achibong, the floor is yours.
Good evening, everyone, and a warm welcome to you. Welcome to our second edition of the Mental Health Dialogue Series. Our theme today is Bridging Research and Reality, Mental Health as a Human Right in Low and Medium Income Countries. This is not just a topic, it's a reality for millions of people living across Africa and beyond, and in other LMICs. It is a call to action for all of us who care about public health, mental health, human dignity, and resilience. It is a collective action, and it is a call to action too. Thank you so much for taking your time to join us today on our second edition of the Mental Health Series. My name is Achibong Owisinke Victor, and it is my honor to host you today as we explore this very interesting topic and welcome on board our distinguished guests who are here to throw more light into the challenges people are facing in the LMICs and also how we can provide help and solutions to these people. We want to take mental health from the papers down to the communities, for the community, according to what they want and not just because we have read somewhere that it's working. We want them to feel involved. We want them to understand that we are putting in the effort. So it's a collective call to action. Today's series is not just a webinar, it is a forum for us to throw more light on mental health as a human right. And together, we're learning how to transform that into reality. Like I always tell with people, there is no health without mental health. Mental health has to be at the forefront because we need good health. For too long, mental health has been treated as a secondary option, not the real health care. But the reality is, mental health is the foundation to human development, to human productivity, to family stability, and to the national progress of a country. Yet, many people still lack access to the basic mental health support. And this is the problem, this is the gap that we are talking about. This is what research has given us. And we want to tell you about the experience. We are here to confront the solutions for everyone. So today's conversation is going to be all around mental health, how it has grown, how the access, equity, and community level is impacting all the challenges that we have in our environment. And we have an incredible panel here who are ready to unpack all that they have prepared for us. And with that, we are going to start our event of today. Our first speaker is going to be Miss Musarat Rani. Like her initial introduction, she has worked at the intersection of clinical care, women's health, and community mental health. She's bringing to us wealth of experience from the forefront because she has a passion, she's culturally grounded, and she has shown that this doesn't just remain on the papers. It has to come to the community. So therefore, we are honored to have you with us today, Ms. Musarat, and the floor is yours. Thank you. Hello, Miss Musarat Rani. We're ready for you. Hello, Ma, are you here? If you're talking, we cannot hear you. Hello, Miss Musarat, the floor is yours. Can you unmute? It's like you're talking and we are not hearing you.
Hello?
Ye-
Hello?
Yes, we can hear
I
you
am
now.
audible now?
Welcome. Yes, you're on now.
Okay. Thank you so much to give me this chance to present this very valuable topic in front of you all people. So,
Welcome here
welcome here
in my
in my
presentation.
presentation.
This is
This
Nusrat
is
Rani.
Nusrat Rani.
1 minute.
1 minute.
This is Nusrat Rani. Okay.
Please, ma, we can't hear you
Okay.
again.
Thank you so
You
much
can unmute
for giving me
yourself.
this very good. Can you change my slide, please?
Yes, we can hear you loud and clear here. Please, can you unmute yourself? We can't hear you anymore. Hello, ma, can you hear me? We can't hear you anymore.
Hello, ma'am. Can you hear me?
Yes, ma, we can hear you.
Okay. So, problem is solved. Thank you so much. Can you go on my previous slide? Okay.
Okay, ma.
Again, thank you so much to give me this very good chance to share my experience with you. This is Nusrat Rani from Pakistan. Please, next slide, please. Yeah, bridging research and the reality. You know, this is very much important topic for us today because we are living in the world where is so many problem. So why this problem is very much important? Let's start to talk about it. I'm sorry for disturbance, but now it is everything is already settled. Good morning, good evening, and good night. In Pakistan, there is night. My talk today is titled Bridging Research and Reality Mental Health as a Human Right in Low and Middle Income Countries. Around the world, we are talking about mental health using language, all right, but what is the actual situation in the world, what we are talking and what is in the reality? There is something very good in the world, but in low and middle income countries there is a painful gap between what is research tell us is possible and what people actually experiencing when they seek care or when they are unable to seek care at all. In next few minutes, I will tell you about and clarify what it means to say mental health is a human right. The research tells us about the situation in the low and middle income countries and highlight the gap between the evidence and the reality on the ground. And also, we will offer some concrete ways to bridge the gap. Next slide, please. According to the WHO, mental health is a basic human right for all people, and wherever they are. When we say mental health, we are not simply saying it would be nice if services existed. We are saying people have a right to. Number one, they have right to available services. There should be services in the first place for the people and all the time, 24 by 7, in near to their house. Number two, accessible services without impossible cost or distances or discriminations. And there should be acceptable services, which should be these services should be culturally appropriate and respectful and non-abusive. And also these services should be good quality services based on the evidence and not harmful myths. Not only this, it is also means that the right to the liberty, independence, and inclusion the community. People should not be without reason detained, restrained, or isolated because of their mental health. So when we talk about mental health as a right, we are talking about both to the care and freedom from the abuse and the discrimination. Next, please. Now, what is the research picture in the lower middle income countries? Research over the last 2 decades paint a very consistent but varying pictures. Globally, over 1 billion people are the mental health conditions today. Most of the individuals live in the lower and middle income countries. Yet the treatment gaps, the proportion of the people who needs care but they don't receive any kind of care, this number of people is huge. Over in many lower middle income countries, 75% of the people who receive mental health treatment, but they don't need 75% of the people they need to receive mental health treatment and mental health care, but they don't receive. And some most important mental health disorder, approximately 76 to 90% are untreated in the lower and middle income countries. When we talk about the resources, these resources are very low. As per research, the median government spending on the mental health only 2% of the total health budgets. And in the lower middle countries, it can be low as because they don't think about the mental health is a very much important issue and they should spend on it. Globally, median numbers of the mental health workers is only approximately 30% over 100,000 people, with the largest shortage in the low middle income countries. It means so even before we can, when we want to talk about the stigma or human rights abuse, the basic reality is this: we have strong evidence about that what works, but almost no resources and the coverage what we need is greatest. So what is the right to reality? From rights to reality, what is the main things? What if we are talking about it, we can say, according to the global statistics, everyday life in the many lower middle income countries context, we see how human rights language often does not translate living experience. Because people with the mental health conditions frequently face stigmas and the discriminations, being seen as weak, dangerous, or less than many things. Many says the stigma is worse than mental illness itself. Can you go back, please? There is a little most important things. Previous slide. Yeah, thank you. And then second thing is this: in some facilities, people are still subject to coercive practices, forced admissions, restraint, and overcrowded wards. So, or they are degrading conditions also. directly violating their dignity and the rights. Financially, families oftenly facing very high out of the pocket cost for their medications and the care, which can push them deeper into the poverty. And the certain groups like women, young people, people in the conflicts or the disaster affected areas, migrants, and the refugees face multiple layers of the vulnerability. So we can say reality is this: we say mental health is a right, but in practice, people are denied that rights through absence of the services, harmful practices, and the social exclusion. Thank you. Next. Okay, thank you. Now, what is the solution of this all? Here we are going to suggest some things. Bridging research and the reality. There are four main bridges which we are suggesting in this presentation. These next slide, please. The first, the first bridge to overcome the problems related to the mental health is integrate the mental health into the primary care. This is very much important to integrate the mental health, so the high burden of the mental health problem will be decreased if we start treatment in the community from the basic from the primary health care. For this purpose, WHO already give us a very good guideline mental health gaps, and it is a very collaborative model, and we can choose this model to treat our social workers. And also, these kinds of toolkits help us how we can train our non-specialist providers to deliver effective care for the depression, anxiety, and the psychosis. They reduce treatment gaps and brings services closer to where people actually lives. Number two is very much important. Heading is co-produce research with the community. It is very important because too much research is still done in the community, but most of them are not with the community. They are doing many researches in the community, but not with the community. So there is need to done researches which should be participatory, community based, and they should these all interventions should be community based. We need to involve the people. We need to inform the people. We need to train the people in the community, not out of the community. Next slide, please. And there is also need to work on the right based laws on the accountability. Yes, in the first slide, in the first solution, we work on the primary healthcare solutions. We need to work and include mental health at the primary healthcare lead. Number two, we need to follow some kind of models to provide care, and there is also need to provide right based laws and the accountability. Many countries are updating mental health legislation, but laws still often fail to fully protect people from the discrimination and the rights violation. We need laws aligned with the UN conventions and the rights of the person with the disability and the WHO guidelines, which emphasize autonomy, informed consent, and the community inclusion. Just it is also important that implementation, independent monitoring, and the complaint mechanism and the civil society oversight. I think there is yes. The way forward, and the last slide was invest in the people and the local innovation. Yes, thank you so much. This is very much important slides because if you check, we need to work on the people in the local innovation. We can't go on the very high fi things. We need to invest on the people at the community level. We need to work on the trainings and the sporting community teachers, religious leaders, and the peers who can provide first line support and the referral. Then we also encouraging local innovation, digital tools, school-based programs, community self-help groups, and then scaling up those that are effective. When it is connected to the community actors, it becomes translate evidence into the services and the right best practices. Here is my last message to you all, that is conclusion. Next slide, please. There are three main steps. Number one, we need to recognize the mental health. Can you go back to our previous slide, please? These steps we need to learn. Number one, we need to recognize the mental health as a right. Number two, we need to close the treatment and the justice gaps. And number three, we need to work together across the role. And next slide, please. There is very simple conclusion steps. Number one, first, mental health is we should know. Mental health is not a luxury or a side issue. It is a universal health human right that shape people's ability to learn, work, or care for others and participate in the society. Research clearly shows that low middle income countries carry a huge burden with the minimum investment and the massive treatment gap. This is not just a service gap, it is a justice gaps also. And the third, we now know that works. Integrated primary healthcare, community based, and the right based approaches, strong laws, and the meaningful involvement of the people with a life experience, we must know. And the challenge is implementing and implementation at the scale. My call to action for everybody in the dialogue, in this dialogue series: number one, for the policymaker, treat mental health is a core public good, not an optional add-on. Number two, for researcher, design studies answer the questions communities are actually asking, and the communicate findings in the ways that policymakers can use. And the last but total is for the participant practitioners, students, and the advocates, keep connecting evidences with everyday practices and keep insisting that mental health is not just about the services, it is about dignity, rights, and inclusion. If we can bring researchers and the reality closer together, then mental health as a human right will become more than a slogan. It will become a live reality for the people across lower middle income countries. And thank you so much to listen me and give me chance to present my presentation. And floor is open for the question answer. Thank you so much.
Thank you so much, amiable speaker. That was a wonderful
And sorry for
presentation.
inconvenience.
No problem at all. Thank you so much for throwing the light here. You've made us understand that for policymakers, it should not be an optional add-on. It needs to be a priority. They need to come out
Yeah.
and put this at the forefront. Like I said from the beginning, we need to implement. We need to bring out interventions with the community. We don't just bring because of research, we just bring it in. We need to know what
Yeah.
exactly the community needs and give it to them accordingly. So, thank you so much for
Yeah.
this. And
Thank you.
we have a question for you, so that's in case your network knocks you off. So let me just go straight to it before the next speaker. It said, from your clinical experience, what are the most common barriers that women face when seeking mental health support, and how can healthcare system begin treating mental health as a right, not a privilege? Like you said, so many people suffer because rights are being violated. Mental health has to be given with dignity. Mental health has to be put in place with respect for the genders, for the people involved. It has to be acceptable, it has to be accessible, it has to be quality. So we leave this for you. How can this be treated as a right and not a privilege? Thank you, ma.
Thank you so much. According to my clinical experience, now mostly I am dealing with the pregnant women in the antenatal and the postnatal. The most important barrier is recognition uh, of the mental health conditions, mental health problem. The most important things people don't know about it, that it is actually a mental health problem. People think that is not a disease, it is a simple thing, it is some out of their thoughts things. And people actually don't accept it. And the rural area, especially where I am working, The healthcare providers are also not trained about how to identify the mental health conditions. Mostly in the community, people and the both don't know about mental health problems. Mostly they take it as a routine problem. Um, so your first question, what are the main barrier? The first main barrier is number one, uh, uh, unable recognition of the mental health problem as a mental health problem, especially in the pregnant women, especially in the young persons, either female or male. And the second thing, inability of the healthcare provider to identify, because most, not only the healthcare providers, other cadre also don't identify these problem. Number three, resources deficiency. They don't have enough psychiatric clinic or enough trained psychiatric nurses or the doctors for their treatment. Number four, if their problem has been identified, they don't have enough money to buy the medicine to take treatment. So in nowadays in the healthcare system, mental health problems also mentioning, and they try to at the first level identify at the first side, but it is still need to work on it. We have lot of problem. We don't have very good resources to work on it. We don't have workforce. We don't have other resources to identify the people. In the previous week, I just reading an article in the Pakistan, in the third, there is high rate of suicide. There is high rate of suicide in the population of the third. The reason is, what is the reason behind it? It is still working on it, but the people don't know they having problem, and there is not so much doctors. There are so not uh, hospital, psychiatric hospital. So these condition mental health problems are increasing day by day, but along with this, to treat them and to identify them, we don't have good resources. We don't have. Thank you.
Thank you so much for that. That last point of having good resources, it's actually a problem everywhere. But right now, since with the work of advocates, with the work of practitioners, it's been brought to the policymakers that we need to create more facilities. We need to bring it out as a single healthcare facility, not just co-joined where you have, before now people have you can have a mental health clinic in a big hospital, and it had so much stigma, it was actually secluded and all that. But right now, because of the work we are all doing, we've seen that policymakers are actually trying to bring out mental health, and we need to put in more effort to we need to
Yeah.
make it louder so that they can make it faster and they can make it very good. Thank you so much.
Thank you
We
so much.
have a question that just came in for you, Ma, and someone said, especially in crisis affected communities, how can we shift mental health care from a medicalized model to a more community integrated, culturally accepted system? Did you get our
Sorry, can you
question?
repeat? Yeah.
How, okay, how can we shift mental health care from the medicalized model, from the hospital medical sector, to community integrated, culturally appropriate system, to make it culturally fit, take it down to the people, to the community itself?
Okay. As I understand your question, how we can modelize from hospital to community. It is very easy now, as I have explained about our WHO model, mental health gaps. Mental health gaps is one of the most important document which actually explain how you can train your healthcare providers at the community level. Along with this, that we also have different kind of models. As I am conducting some kind of researches for the health provider, the one of the most important model is mental health first aid course. Mental health first aid course is one of the most important model which we can use for everybody. It is one of the most important model, mental health first aid care. Mental health first aid care is a very much resource through which you can train all of your community, from healthcare provider to school teachers to counselor to a very good person who is ready to work on it. Through this model you can early identify the problem of the mental health in the people. Number two, you can explain them, then you can refer them to the doctors, and you can also explain their family can take care of your patient with a mental health problem. So there are two main resources which are right now I am using. The third most important thing which I am we are applying, that at the community level we identify mental health screening now. In our countries also this process has been started, that along with the physical condition we also focusing on screening of the mental health problem. In some areas we are arrange some medical camps, and from these medical camps we are referring the patients to the tertiary care psychiatric hospitals. Along with them there are many NGOs working in the Pakistan who are working and providing services to the people on the mental health. Now from the government side there is also a helpline, yeah, which people can use free of cost. So in Pakistan work has started to promote mental health and to relieve the patients and prevent the patient from mental illnesses. Although it is not so scale up, but problems has been addressed in the Pakistan. And so different partners, not only the government but also private organizations, NGOs, and the institutions are working on it. Nowadays, the most important things, awareness raising is also increasing in Pakistan. We are arranging mental health awareness sessions in the different communities, in the school, in the colleges, in the universities. And there are also conferences held in the Pakistan on the mental health. So in Pakistan, it is started to talk about these issues. So the most important thing which we try to take this burden from tertiary care hospital to at the primary level. At this stage, we also included mental health in our curriculums, like in bachelor in the BS midwifery curriculum. We also include in the BS nursing program, include in the MBBS curriculum. So these problems is also addressing through our curriculum. So this is situation. But still we need so much work to done. We need to done for the increasing the mental health awareness. If you are, I also I will be very happy to work more in your program and give awareness on it, because this is not only the problem of the Pakistan, it is a problem of the all over the world, like especially in the Africa. It is very much important problem, and the basic target of this problem is women. Women are suffering more, especially in the during pregnancy, and this rate is very high in these days. Perinatal mental health conditions are increasing day by day, so there is need to specially work on it, because if a postnatal woman is suffering from it, it definitely very dangerous for herself and her child also. Mental health problem increasing in youth also. I don't know what is the reason behind it, but it is increasing, and this is alarming sign for us. We need to work on it. So problem is also increasing, but we also trying to overcome all. But this is situation here.
Thank you so much, Miss Musarat. That was very explanatory and very listen. It was actually very eye opening. But when you talked about is increasing in the youth, we see that like there was a recent study I saw and said the major cause is actually pressure, peer pressure. We
Yeah,
have so much going on with the youth these days. Everyone is trying to catch up. They are trying to meet up one deadline or the other. Everyone wants to accomplish all their goals at a time. And then we have other factors, financial factor, social factor, family factor. You have so much expectations. And then we also see school stress for the youth too.
yeah,
Academic stress has been shown to actually increase mental health issues, and most of them really don't know how to cope with it because we don't have a planned mental health system in educational sector. You see, everyone they say read, 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 read. They don't really actually give you the time to free yourself, to actually understand your environment, to actually calm down. Too much of everything, it's not good, and
yeah,
some of them actually resort to substance use, and that's why we've seen there's an increase in substance use amongst youth, especially those in the university system. So and when
yes,
it
you are
comes
right.
to mental health,
Yeah,
yeah, when it comes to mental health, we are really working hard. We see so many persons, so many organizations are trying to like create mental health retreats for youths that you can allow them to talk, and then they have the stigma problem. Nobody, they don't have trust, they don't
yeah,
have people they can actually talk to, because the elder ones, when you talk to them, they still use the olden days method. These days everything has changed. There is
yeah,
now digital intervention. So many things are happening on social media, which actually influences them also. So the way we advise people before now is not the same way you advise people going forward. So that is a major reason why we're seeing the increase in youth. And then when you talk about youth in crisis setting, it's really a very difficult one because most of them have lost self-esteem, most of them have lost focus on what the future holds.
yeah,
So when we talk about low and medium income countries, we still have so much to do. Since we have seen the
yeah,
researches, what research is saying, we are calling on communities, we are calling on advocates, we are calling on organizations, we are calling on people that are just passionate. Let's come together. Let's do something that can provide help. Let's do something that can help. And
yeah,
with that, we also go to the part of the maternal, the mothers. Pregnancy on its own has its own difficult situations. You have so many hormones working, and then
yeah,
mental health is not something that people talk about for the pregnant woman. They actually see the baby, the baby, the baby, and they neglect the mother. You have the
yeah,
hormones working on your psychology, you have hormones working on your body. You start losing self-esteem because of the different changes. You're not used to it, and this is what's happening. We need to create support. We need to create an environment where the mother is also seen, not just the baby. You see people come to visit a mother, and they say, oh, your baby is beautiful. You leave the mother aside. It's not intentional, but over time, the brain can be a very funny one. It gives you one room where you can overthink things and think into the wrong direction. And that is why we have a platform like this where we can
yeah,
talk about mental health in all aspects, especially in our communities as such. So thank you so much for throwing so much light into this
yeah.
topic of
I just want to
today.
adjust a little comment.
Yeah.
Yeah, I think the
All right.
family system has been broken. We are away from the religion, and the third, as you have mentioned, social media pressure. These are also most important elements in increasing mental health issues. Thank you. I just recall thoughts. Thank you so much.
Yeah, social media has really exposed so much. It has really, especially people that invested in it. That's why we keep advising people to actually take break from the social media. Social media is actually not real life. We have so many fake things happening. Yes, this is the information age. We have informations there, but we also have some fake articles running. We have some fake lifestyle. That's why we have content creators. These are content people used to drag your attention, but so many people feel so invested in it. Like recently, I had some talk with some secondary school students, and one of their major problem was social media. They want to be like this person. They look up to this person, and then they actually don't have access to know what the person has been through, how the person is navigating. They see only the results. It's not really that easy, and when they meet
Yeah.
challenges, they
Yeah.
are not prepared on how to cope, on how to go through it, and then they
Yes.
fall back. And you
Yeah.
see, most people actually resort to suicide ideation. So you see, all these things are actually linked. Everything is linked. That's why I keep telling people there is no health without mental health. For you to be totally healed, for you to be socially fit, emotionally fit, physically fit, your mental health has to be 100%. It has to be checked. You as
Yes.
a person have to be intentional about what to do, how to do it, where to do it, and when you can do it. So
Yes.
thank you so much for
Yeah.
highlighting social
Yeah.
media there.
Yeah. Yeah.
So
So your question is, I think
the
I answer of this question. We are
yes, you have actually
working.
given the answer.
Yeah. We are working on the universal health coverage. We are providing
Yeah,
services and the doorsteps for the people. So automatically, we are working on the universal health coverage. We have definitely will shift from tertiary care hospital to community-based interventions. So this is one of the most
yeah,
important steps the working government of Pakistan now working in the Pakistan. We have very good basic health units. We have rural health centers. We also have the different community interventions. That's why, and I think now we have very good examples to shift the tertiary care hospitals burdens into the community basic health units. So we have different models we can work on according to that, as we mentioned previously. WHO also give this model. So thank you. Next question.
well, that's beautiful. Pakistan is actually going very far with it, and well, we are looking towards us going very far too. We have achieved the level, but we still need to do more, and that's why we are still calling on policymakers. We're still calling on the government to actually give us a platform, help us invest more. Especially in your slide, you talked about the less than 2% of the health budget. It is a thing, and we are hoping that eventually they're going to work towards it and increase it so that it can provide quality health care for everyone in our environment. It was so much fun to talk with you today, Miss Musarat. Thank you so much for this
Thank you.
opportunity.
Yeah.
And then we move on to the next one. We have
Sure.
Mr. Vincent Balume.
Thank you
He
so
had
much.
an issue joining. You're welcome. He works with refugee community. I really wish our network would allow him join, but I think his part is not. But we can actually just have a glimpse at his slide. Please, can you give us his slide so that we see what's happening in the refugee camp, in the displacement camp? We see these are people that it's not really an easy one for them. This is a community focused presentation by Mr. Vincent Balume. We've had his short bio read to us at the beginning of it. So he said research and policy anchors. We have the psychological first aid, providing human support and stabilization principles. Then we also have WHO, UNHCR, UNICEF, providing guidance and community, MHPSS operational guides, and these are all what the research has shown us. Evidence backed community approaches, they help to train volunteers that provide immediate support and safe referral, especially in the refugee camps. They also have peer support group and psychosocial groups. These are groups that have been placed in these camps to help reduce isolation and common health system. From research, we have found that the rate of mental health issues, especially in refugee camps, are very high because we have people from different displacement zones. We have people from different crisis settings coming together, from lack of food, lack of water, lack of basic health care, and then loss of loved ones, especially. And then we have several other people that have lost their source of livelihood. They have lost so many things that are precious to them. So because of that, they have support group, they have psychosocial groups which have helped which have been kept to help them reduce this health system. And also they have community health workers. These are the persons who have been trained to provide this help. Then we have economic and protection intervention. They are used to address the social determinants of health. In as much as we talk about this, the other parts of health, we also have the social determinants of health. This can be seen especially during the lockdown in COVID-19. If you remember, I think that was a very harsh reality where it met everybody. I don't think anybody was actually free from that because it was unexpected and we had a worldwide pandemic. So we have the economic and protection intervention, which actually help people provide skills for them so that they can come back from what has happened to them, and also help them to provide for themselves, provide for their families, provide for their loved ones. Then these are all practical community interventions from Zaleka. Zaleka is the refugee camp. They have the PFA community referral pathway. Then we have the peer support, like we talked. Then we have the case management and protection linkages. They strengthen coordination between the MHPSS and GBV, child protection, livelihood teams, and then they have safe space. Nowadays, we see different support groups coming, we see different safe spaces so that people can be able to talk, can be able to lay out their problems. These are spaces that you can even cry. You see, some persons might not want to cry in public so that they won't laugh at them, they will be stigmatized. But these safe spaces actually provide space for people to actually uh, you can gain skills, you can actually pour out your mind, you can actually relax, you can actually do exercises that can help rejuvenate your health. Then we have the community led problem saving action groups. Let's use these community priorities to tackle stressors like water, sanitation, food, and access. We can tell you that in crisis setting, in refugee camps, in different places where in communities where they are maybe rural and very deep, you have so many infrastructural problems. You have lack of water, you have poor access to good food, you have poor access to clean environment, all that. So with this community led problem saving, it actually reduces the gap, the problem, and help provide solutions. Then they have the psychoeducation anti-stigma campaigns. These are through radio messages, through the peer support group, in the safe spaces, the volunteers, the community health workers. All these people actually help provide the psycho education. So he just talked about how the peer support circle works, the step by step. And we go on to the next, the implementation roadmap for Zaleka. They have a 90-day startup plan, week 0 to 2, stakeholder meeting, mapping of services, recruiting facilitators, week 3 to 6, training, produce materials in local languages. Like we said earlier in Miss Maserati slide, she said you create interventions with the community. And so we see you produce material in the local languages so that people can understand. there are some communities that actually don't speak English. You see some communities speak in French, they speak in Swahili, they speak in different languages, and then we need to produce material so that they can understand. And if you want to talk about those that cannot read, you also have the community health workers who can actually help translate this information, talk to them and tell them what is actually the information being passed. Then they have the launch of the pilot groups, and then in every intervention that you carry out, there have to be a monitoring and evaluation to actually check the impact of the intervention. Is it working? Is it helping the people? Is there a change in their lifestyle? Is it contributing to the community positively? Then we go to the monitoring and indicators, simple and feasible. The number of people they have reached by age, gender, or nationality, the number of PFA, peer sessions conducted, and the attendance. You see, in every session you conduct, the first session usually has a lot of people attending. Eventually, you see the number of people reducing. Not because they don't want to come. Sometimes there might be challenges. Sometimes it might hit the nail and some people are scared to face it. Sometimes they might be having all that, maybe money issues, maybe family issues. So for you to know if this is impactful, you need to put an evaluation team. What has happened? We need to go back and pick up these people. How can we provide support? How is our intervention not helping you so that we can use another format to help? That we have percentage of people referred to who complete follow, or people who seek help. For you to get help, you need to be intentional. In a camp like that, where we provide help, we actually see people going back. But if they want it, if they are this is the problem I have now, I am ready, I want to attend to this, I want to find a solution, I want to be completely healed. You see people complete their follow up, they go for their referral sessions, they attend their sessions, and they become better persons and become advocates and also help. This is where we have the peer support groups. They form these groups and can also provide help to people who need it. So we also use short tools to avoid survey fatigue and make monitoring feasible for volunteers. Our previous speaker talked about how they do the check for mental health illness issues in the community. So we have tools that we use in confirming, does this person have depression, does he have anxiety. There are different tools now that are accessible, so you can't just say anybody wakes up in the morning and tell you just because you feel you cannot sleep, just because you feel somehow, that means you're having mental health issues. No, these tools actually, they list out what have been your problems, how have you been reacting to this problem, how can we provide support, like on your own, how do you feel you need support. So based on your responses, we'll find out if you have this particular issue and how we can provide help for you. And I say risk protection and ethical consideration, especially in a camp like this. We have confidentiality, a do not harm, cultural sensitivity, and burnout. These are issues that actually happen, especially when you're carrying out interventions in what do you call them, in refugee camps. So these are partners and resources to tap into. In the Zaleka camp, they have been putting in one or two efforts in order to provide help to these people. And Mr. Vincent Balume has been working with them for a while. He was supposed to be in the best position to give us a current, up to date information on what is going on. But we thank him so much for sending this slide to us. It has made us to understand the basic steps that they've actually been putting on in the camp, the interventions that have been going on. And we know that we have seen results from other camps. So we believe that this is actually going to provide solutions and help reduce the number of mental health issues in Zaleka camp. So thank you so much, everyone. And okay, we actually have a question from our initial form that was kept. It said, in refugee settings where resources are limited, how can we empower communities themselves youth leaders, and families to sustain mental health interventions even after NGOs leave. From works that have been done, we have seen the peer support group. These are groups that are put in to continue to maintain sustainability. They also have the community health workers who have been trained, the psycho education that have been going on. When you train the youth, you train the leaders, you train the immediate families. This will help them provide first aid. And he talked about the psychological first aid that is being provided. Are you having an issue? How do we provide help to you? You start from there. You identify there is a problem. Then the first aid you can give to the person before you refer them to the major hospital. So these are how we are empowering communities now. We teach them, we train them, we tell them what exactly they can do at that first point. You don't really need to go straight to the hospital to say you need medication. Sometimes you need therapies that don't need medication. You need to take some time off. Their exercises, their nutrition, their lifestyle modification, behavioral modification that can be recommended for you that can help. So these are ways that they've been trying to empower communities. Please, Miss Musorati, do you have anything to add for us according to what we just finished reading from Mr. Vincent Balumi?
Yes, I just want to say this question: how we can enable our community less awareness as we these programs help us. We need to empower ourselves also. Like we are educated and we know many things, so we need to create this kind of information to all our families, our family members. We have just very good models for the to empowering people. These are very simple. There is no need for high-fi qualification, and we can train the people from the family, from the teachers, from the good educated, and sometimes non-educated people also very helpful. We can teach them by pictures, and but there is a need a consistent plan how we can empower our family, how we can empower our youth. You can utilize your volunteers from the colleges, from the youth, from your religious background and the institutions. But yeah, just to think how we can develop a very good strategy to empower our community. There are ways, there are certain models we can utilize. We don't have need so much big NGOs to work for us, because sometimes problems are very much little. They just need to identify, and we can give counseling, and this problem can be solved out, and the major problem we can refer to the problem trustee care hospital. So I just said this. Thank you so much.
Thank you so much, Ms. Musarasi, for that. And also, the practical approach that is being used in the Zaleka camp is called the psychosocial support through accompaniment and advocacy. These are provided to the people there because the
Yeah,
major mental health issues that is found there is PTSD, depression, and stress.
yeah,
So we can see that psychosocial support is the number one basic help that is being provided to people.
yeah,
Then we also see that they empower the communities and the individuals client through client empowerment model. They use their strengths and their experiences so that they sit together and they exchange ideas, they exchange their experiences, how what they are facing, how they are coping, and this can help them to have a sense of togetherness, a sense of community. They can come together and say, okay, if this works for you, this works for me, we can join together and do the two and see if it will give us a better result. And so that is how they have been actually trying to cope in the Zaleka camp and the community. Okay, we have another question. He said, you work directly with displaced and vulnerable population. What practical community-based approaches have been proven most effective in turning research into real-life mental health solutions? Okay, that's what we just talked about, the client empowerment model, where people have to share their experiences. They need to come together to talk about what's been happening. It gives them that sense of understanding, makes you know that someone else is going through the same thing, and the person is trying. It's just like when people talk about, you tell people, bring your problems to the table, and then you see that people are going through a lot, but they are coping. There are different coping strategies. Positive coping strategies are what we encourage, because we also have negative coping strategies. If you come to the camp, you see that there's so much issue of substance abuse and substance use. You'll be surprised. This is how people used to cope, and it has shown to give them temporary referral. It's after the effect wears out, the mental health issues becomes worse, and at a point where there's addiction, you cannot help it. So addiction on its own is a different mental health issue entirely. So there are different kind of issues that are being tackled here. So it's not one pathway that works for all. There are different approaches that can actually work together. So we have another question. I think this is the last question we have for today here. Yeah, it said, what role can youth, peer support groups, and community volunteers play in bridging the gap between insights, and everyday mental health realities in their community? Miss Musarati, please, can you help us with a little contribution to that?
Yeah, sure. Yes, youth and the peer sport groups and the community volunteers play a very good and very important role, because they have so much energy and that they can, and it is also evident that if you train youth and you involve them peer to peer education and peer to peer counseling, and also community volunteers, in which include your religious leaders, your teachers, and your elders group, family heads. You, if you train them, you they will help you, because these are the people who have a very good positive minds. Most of them have very good positive minds, and also they know about their community. When you train the youth peoples and the other targeted community people as your volunteer for the for solution of the mental health problems, it will works, as evidenced by my own clinical experience, that where we are working, we have taken the people from the community. Mostly they are young people, and we prepare them on the model, and we send them to the people with a mental health problem. Through their peer education, through their counseling, and through their existing religious and the practical social and the psychological tricks or evidence based practices, they motivate the mental health problem people, and the results was very good. So your result is in yes, we can use youth as a peer sport groups and the community volunteers to help us to between bridging the gaps between research insights and everyday mental health realities in the communities, because they are the people who are living there. They know about each and other things, and we can train them, we can invest on them, and we can continue keep in touch with them to make a sustainable solution for the community. So we need to focus on this solution for our mental health problems. So this is good. Thank you.
Thank you so much. We all hear the youth are the future of every community. So the youth have so much to give. The
Yeah.
youth are vibrant. They are still in their youth. They are still
Mhm.
very active. They are passionate. They are energetic. So if we train them, they can help, they can provide support to the communities. Recently, we have seen a rise in community health workers that are being trained. These are not core professionals. There are people from the community that are being picked up and trained so that they provide help to the community. They know these problems. They are in the community. They know what is happening. They know how to imbibe all the cultural activities, all the cultural rules, and then they actually know the stigma
Yeah.
that is going on in that community. So they know how to approach each situation. Funny enough, they actually know more people that are hiding with their problems. So when you see someone from your community come to talk to you, you'll be more receptive compared to an outsider. So we have community volunteers. They play a very serious gap, because a very serious role, because the real mental health reality is different from what we hear on radio, what we see on TV. From in the homes, it is more severe. There are so many people that are smiling, but they all have issues. So we really need to know how we can attend to them. When you have peer support group, you see your fellows come together, like the experience we talk about in the Zaleka camp. The support group gives you hope. It gives you where to fall back to, so you know that you are not alone. So as we come to the end of our session, I will give Miss Musarat a minute to give us her final say and conclusion on this series.
So much. I would give from this point that we need to work our peer support groups and the community, because they are our eyes, they are our hands, and they are our tongue in the communities. We need to empower our communities to make a sustainable solution for the community. We need three things in the community. We need peoples who can identify the mental health problems. We need people who can refer them, and we need people who can follow the people with the mental health problems. And these three works can be done by our youth, our peer support group, and the community volunteer. So our topic, we can find out our answer through this last question that we need to work on it. This is my message also. Thank you so much.
Thank you so much, Miss Musarat. It was an honor to have you on this program. It has been an interesting session, learning from your wealth of experience. Your
Thank
insights
you.
to answer essential questions that we need. Like mental health is a right in every community, in low and medium income countries, even in the high income countries, global north, global south, east, west, north, and south, everywhere worldwide, mental health is a right. And today we have seen that is not just theory. We need to take it from the papers, from the research, down to the community. We have learned different topics. We have learned how culture matters. We have learned how community matters. We have learned how support and experience actually matter. It is very important that we actually bridge this gap so that we don't be all talk and no action. Thank you so much to everyone who has joined us
Thank you.
today. Thank you for your questions. Thank you for your engagement. Thank you for your dedication to build a mentally healthy community and environment. We need to create more resilient communities. We need people to learn more resilience because it is not easy. The world is not getting easier, but we need to be stronger. We need to be mentally checked. We need to be physically checked. We need to be emotionally checked and socially checked. And that is why we have this platform to bring information to you, to bring what the researchers are saying, to also make you know that there are advances in mental health solutions, there are advances in mental health researches. We are taking it to the communities. We are improving awareness. We are improving education. We are improving sensitization. We are going far. We are passionate advocates and we are willing to take the gospel of mental health straight to the communities, to the people who really need it. So let's keep this momentum going. Let's tell everyone that mental health cannot wait. And together we are going to create a mentally healthy world. Thank you so much, everyone. My name is
Thank,
Osinke
thank you
Victor.
so
I was your host
much.
for this
Thank
event.
you.
You're welcome. Thank you so much, Miss Musarati. It was a very
Thank
beautiful
you. Thank you
session
so
with
much.
you.
Thank you so
On
much.
FIRAT, we have
Thank you. Thank you.
you. Welcome, ma. You're welcome. On FIRAT, we have different dialogue series. We have the nurses diary, we have the orthodontal diaries, we have the medical student diary, we also have the maternal health diaries, we also have the Install Africa Research Group. We hold this dialogue series monthly. So you can follow our website. If you registered, you can actually get information concerning our dialogue series sent to you. So we'll see you next year when we have new
Enjoy.
topic coming on. Have a lovely holiday, have a lovely new month, have a lovely week ahead. Thank you and have a
Thank you so
wonderful
much.
evening.
Thank you.
Bye.